Welcome. Thank you for attending the 2023 Foustanellas Endowed Lectureship. I want first to thank the family of Mr. Peter Foustanellas, who unfortunately, as you know, passed away several years ago. But his family continues to support the Heart Institute. Without the generous legacy and gifts of Mr. Foustanellas, this lectureship and many of what we do in terms of innovation and research and thinking out of the box in the cardiac surgery or the Heart Institute would not be possible. So we're very indebted to Mr. Foustanellas' family and to him in particular in his memory. Today's lectureship is a once a year endowed lectureship. It's one of the few named lectureships at the Heart Institute. We're very pleased to have to speak before us today Dr. Douglas Johnston. Doug goes way back to several of us, including yours truly. He completed his MD at Harvard Medical School, I think graduated in 1998, and then went through presumably a gruesome general surgery residency at man's greatest hospital, MGH, also better known as Massachusetts General Hospital, but typically nicknamed man's greatest hospital. And so finished it, did research, and then went on to a cardiac surgery, cardiothoracic surgery fellowship at the Cleveland Clinic. And the rest is history. Did extremely well at the Cleveland Clinic, rapidly identified as we were both young surgeons at the time as really a true rising star. Did a lot of the very difficult cases, bad redos, multiple valve endocarditis, redo, etc. And Doug was quickly promoted to vice chairman of the Cleveland Clinic cardiac surgery program. Now, with in our little world of cardiac surgery, a few years ago, a lot of rumors came around that Doug was being sought by another great US institution, Northwestern, to be their next chief, and was successfully recruited. And I think you've been there now, Doug, for about 6 months or so. So Dr. Johnston provides us with great perspective, obviously, from his very vast, despite his young age, very vast surgical experience and leadership experience as well, and having been at 3 of the world's most prestigious institutions in terms of training and practicing. So we're very delighted. Doug, you're in great company with, this is obviously a very prestigious leadership, and we could find absolutely no one can be more fitting to this great named lecturer than yourself. So we look very much forward to your insights, to your presentation, and also the time that you spend with, very importantly, with our trainee and the nice interactions that you've had with us and with them so far. So welcome to Ottawa, and thank you for having accepted our invitation.
Well, thank you, Mark, for that very kind introduction and for having me here. Thanks to all of you for devoting an hour in the middle of your day. It's a tough time when what I saw was a very busy operative schedule. And also want to thank the Foustanellas family for making something like this possible. I think the idea of propagating information between institutions is something we sometimes give lip service to, but you guys actually do it very well here. I don't have any disclosures related to this talk, other than the fact that when I was thinking about what would be interesting to talk about at this institution, and knowing Mark as I do, I thought, you know, there's really only one area of cardiac surgery I could remotely consider myself an expert in, which is pericarditis. And it's something you're going to see not very often. And I can tell you everything you need to know in about 5 minutes. So we can reserve that for the Q&A afterward. And I thought maybe we'd talk about something that's a little bit more personal, which is, you know, a journey from kind of thinking about problems early in your surgical career to how to implement solutions on a broader scale, which is something that I've been thinking about as I took on this new position. And in particular, talking to the trainees, I think this might be of more interest than the esoterica of how to treat constriction. So this is a reimagining of the first operation under ether, which was done at the Mass General Hospital. And you can see John Collins Warren, who's actually a very distant relative of mine, was the surgeon who performed that operation, like a 20th cousin or something. But I think what this illustrates is, you know, this is sort of the nature of the great man or great person theory of surgery, right? There's Dr. Warren, who's operating. There's William T.G. Morton, who's delivering the anesthesia, who's actually a dentist. And this is in the Ether Dome at the Mass General, which is still there if you get to go see it. Very small auditorium, but very high tiers where everybody would watch the expert at work, right? This is the old school team theory of surgery. One captain, a lot of foot soldiers or sailors who are doing the work and following along, but it's a top-down approach. And that was very much of my surgical training at the Mass General was in that mode. This is the institution that I had the opportunity to go to after almost 11 years in Boston. And this is the founding group of the Cleveland Clinic. So the clinic was founded by 4 surgeons from Cleveland who were what they called visiting surgeons at the time at the Lakeside Hospital, meaning that the surgeons would have private practices. You go into the hospital, you do a case, but nobody was employed by the hospital or worked for the hospital. And then they went to France in World War I, and this was the crew. George Kreil is the guy, he's sort of just to the left of the guy with the mustache, but one of the founding fathers of general surgery. And what they found in wartime was that being together in one unit, the surgeons, the nurses, the techs, all the support staff, that they thought they delivered much better care in wartime conditions than what they delivered in Cleveland. So when they came back to Cleveland, they decided to found an institution that modeled that. And this is the first Cleveland Clinic building. At the time, it was one of 2 staff model institutions in the United States, the other one being the Mayo. And it's interesting to note that those are 2 of the institutions that are still at the top of the heap in terms of quality, but a very different foundational principle than most of the institutions that we've trained and practiced at, which is it's a group practice that owns the hospital. And it's very much of a team approach. I mean, there have been some modifications over time, but at the time it was revolutionary. And the fact that Cleveland is a city of about 300,000 people, and it's the largest heart program in the United States, was a testament to the fact that that was a success. And a lot of my kind of thought process about what makes a great surgical program, what makes a great surgeon was changed in a good way by growing up in that environment for cardiac surgery. But this is Cleveland Clinic operating room for one of the first pump cases there. You can see the size of the team. This is Don Effler doing an ASD repair in the early 1960s in Cleveland. And then in the last 6 months, I left an institution that I've been at for 17 years and made the transition to Chicago. This is the front door of the Bloom Heart Hospital, which is where I spend most of my time now. And this is my OR in the first few weeks in Chicago, which, you know, I think if you take anything away from the previous 2 pictures, is it's hard to know what's going on with the team from a snapshot. Right? We have a bunch of people who have roles in the operating room. They're very different roles. It's really hard to tell from this who's in charge. You can sort of see me there, but you don't know who's doing that. And, you know, here's a scene that I stole from your website of the operating room here, you know, kind of the same thing, right? This is a big team of people. They're all very focused. You can see the eyes are all in the direction of the field, except for the anesthesiologist who's looking at the monitor, which is critical, right? But it's very hard to understand how effective we are at doing what we do from looking at what goes on in this situation. And I'll come back to this in a second. And I hope you'll suspend disbelief for a little bit and indulge me as I take you through a little bit of my own thought process on from focusing on one disease and how do we treat one disease to how do we look at the larger picture of delivery of care and is that effective? So this is a slide I showed in my first staff meeting, you know, brand new at Northwestern. And I said, I'm going to come in and just ask some questions. And so I put these up and I said, where do you guys want to be? Where does the team see ourselves in 5 years in these areas? Where do we want to be reputationally? How many operations should we be doing? There's an assumption we should be growing rapidly, but is that the right thing to do? What does our quality look like? How do we measure it? Where do all these other areas sit? What kind of a place do we want to be? Do we want to be Cleveland Clinic, 98% clinical with a little research thrown on top? Do we want to be a primarily research institution, which is what cardiology looks like at Northwestern? There's a lot of people who are 10% clinical. Do we want to be somewhere in between as surgeons? And where does education fit into that picture? And what we came out of that was that based on where we are right now, growth is a key component. And I'll have to give kudos to this group. I mean, you've had unbelievable growth in the last decade. We can aspire to get there. When I arrived at Northwestern, we were doing about 950 pumps a year. I think you were about 1,200 when you started, Mark, you said, and now you're orders of magnitude bigger in a few years, which is a very difficult thing to achieve, and improve quality. So this is kind of what we put up there as aspirational values. We're going to grow. We're going to rigorously assess our quality and outcomes and improve those. And we're going to make it sustainable so that this mass exodus of nurses we had during COVID is a thing of the past, that we're not relying on 70% agency nurses in the ICU. So when I started, between the time that I started and now, we hired 61 ICU nurses, to give you an idea of how far behind we were. So does that make for excellent quality? Questionable. So how can we get to a more sustainable future? So I'll just take you through that thought process in 3 steps. And I'll start it with valves. I spent most of my early career thinking a lot about valve surgery outcomes, durability of valves. How do we make decisions early in the life of a patient that are lifetime management decisions, which you all think about every day. And this is an opportunity. We had to look back at the entire practice of valve surgery at the Cleveland Clinic. So this is about 70,000 valve operations going back to the early 60s. Obviously, kind of different prostheses, bubble to the top, different techniques. Obviously, we're seeing the rapid growth of TAVR, but you can look back and see the rapid growth of bioprostheses, and we wonder in 15 years where we're going to be, what this will look like in terms of a landscape. Very unpredictable. There's this assumption that there's this inexorable progression from surgical valves to TAVR, but we forget that there is technological advancement in every type of thing that we do. So I think the predictability of this is a little difficult. And I have to show a little video because I learned so much about this from Mark. And I won't even go through the whole thing, but to think when I started my career that I would do all of my isolated AVRs, or 99%, through a mini thoracotomy incision. I'm not this fast, this is way sped up, but that this would become a routine and safe approach, and that we could understand enough about how to do an operation through an incision that's 2 inches long to do it well, I think was almost unheard of. Certainly when I left the Mass General, there was one minimally invasive operation that had been done in the history of that program, went very badly. There was no planning. It was a perfect example of how not to do it. So I'm not going to focus on the technical aspects. So I'll just leave you with that as how fast things are evolving, even before we get to transcatheter approaches. But this has been our own history at Northwestern up until my arrival in terms of growth. And you can see there have been periods of, kind of slow incremental growth. Those exponential periods have been one of 2 things. They've been adding new surgeons and potentially new approaches, or they've been adding hospitals. In our situation in Chicago, massive population, vast disparities in access to care and health status, in a geography that's very constrained by traffic and those kind of things. So as we've added capacity to bring patients in, the volume has grown. And obviously one of our goals is to keep that growth moving, knowing, as we all do, the volume outcome relationship. But this is what we look like as a heart and vascular institute. So these are all the locations where you can get diagnostic or therapeutic care. 4 of those locations have heart surgery. So downtown Northwestern Memorial, which is right on Michigan Avenue, welcome you all to visit. It's a great place to spend some time. Right in the heart of the city, that's our downtown campus. If you live 30 miles away, it's going to take you 3 hours to get there in rush hour. So there's a lot of geographic constraints about where patients can get their care. So if we're going to leverage that and ensure that we're delivering top quality care, one of the tasks that has to be done well is to assess quality, right? And this is a word that we give lip service to a lot. So what's the quality, mortality? What are our STS star ratings? So, this is what it looks like from a public reporting standpoint for CABG. And, in full disclosure, we've waffled on the borderline of 2 and 3 stars for coronaries. As we've added more hospitals, because our volume went up, our star rating's gone up, not because we're doing a better job, but because volume is foundational for a 3-star rating. And when you really look at the outcomes that we get at the main hospital, I'm not sure we've done any better. We've just gotten a bigger denominator that's driven some of that care. So there are a lot of nuances to this, but obviously this is a publicly reported aspect of what we do that's very important. Let's look as we go back and look at valve disease, and I'll just spend a couple of minutes on this, as I said, because this is my early passion in my career was, how do we treat the young bicuspid patient who has 50 years of life left and has to figure out what to do. And this is, I think, a remarkable graph. So this is again, Cleveland Clinic data going back to the first years. And we don't have granular data back to 1964, but there was a paper published in 66 on the first 100 AVRs at the Cleveland Clinic. Guess what the mortality was? Anyone want to take a stab? The early 60s with very primitive oxygenators and a Starr Edwards valve. But you can see there's been this steady kind of inexorable decline in mortality that brings us all joy. This is us getting really good at taking care of heart patients. But when you think about what we do now, and take a relatively simple operation, mitral valve repair, aortic valve replacement for isolated disease, why is that mortality not zero? Why is it 0.5%, or in mitral valve repair, 0.25% or 0.2% even? I mean, where is that last drop that we can squeeze? So this is a paper that some of you may have seen. We finally got published this year in JTCVS. It's been sitting with the editors for 2 years and was presented 2 years ago at AATS. And one of the reasons that we couldn't get it published was people said, this is just advertising. You're just telling the world that you're better than everybody else at AVR. And we said, well, we're not. If you look at the graph on the left-hand side, what that shows is observed versus expected combined morbidity and mortality for isolated AVR in healthy patients. So this is STS risk of less than 4, so low risk patients. What it shows is that nationally in the US, or of all STS reporting institutions, the expected risk is about the same according to the score. In the beginning of the cohort in 2005, we were pretty much like the rest of the country. And 12 years later, we were a quarter of the rest of the country. That's not one surgeon, that's not one intervention, that's an iterative quality improvement process. And I can't even point to the major factors that drove that. I can tell you what the process was. And one of them, and I'm not taking credit for this, but when I joined as a fellow in 2005 and then as a staff in 2008, Bruce Lytle said to me, I think we got a quality issue. And I'm not sure whether it's reporting or whether it's really quality, but I want you to work on this problem. And I want you to take 2 days a week to work on this. And as a new staff, that was like an arrow in the heart. I mean, I was like, that's going to kill my practice. I don't want to be an administrator. I don't want to work on quality. But it was one of the best things that ever happened to my career, because I had the chance to dive into some of this stuff and to try to understand what was going on. And I don't take credit for any of the improvements that led to this. But what I can say is that we learned a lot about all of the gaps, not only in care delivery, but just in understanding how sick our patients were, how we triage the documentation. Putting all those together over a decade is probably what led us to get that much better at taking care of those patients. And I will say this is all pre-TAVR. So there's no low-risk TAVR effect in that cohort. And what we show on the right is that in this cohort, the survival, long-term survival for a low-risk SAVR is actually better than the matched general population, which is pretty remarkable. Obviously, we self-select for people who don't have cancer and those kind of things, but I mean, a pretty remarkable achievement. We showed the same thing is true in redo AVR. So this is the red line is a redo, the blue line is primary. Sometime around 2015 at the Cleveland Clinic, patient for patient, the reoperation risk, the risk associated with making a redo sternotomy went away, except for transfusion. That's the only thing that's higher, but the mortality and morbidity became the same. So that's an expertise problem or a patient selection problem. We did one or the other better, but that is a remarkable quality achievement. And I bet if you looked at your own data, you'd see exactly the same thing, that there's a period of time when that expertise comes to bear. So this is where I want to flip it into a slightly less traditional thought process. And it's to say, if we look at the right side of those previous graphs, we can all pat ourselves in the back and go, we're good. We have excellent mortality. We're better than the rest of the country. You know, places like Cleveland and Northwestern and Ottawa are so far above the curve that we're like hitting out of the park. Let's not worry about it. But if we go back to the values that we think are foundational, and these are the Northwestern medicine values, I took them right off the website. And I found very interesting, if we take the Ottawa Heart Institute values and put them next to each other, essentially you have 4 commonalities there. And there's one additional one, which I really like, which I want to spend a little time talking about at the end, which is partnering. You know, this is what we should be aspiring to. If we're putting our patients first, number one, we have to look at things from their perspective. And number 2, we have to think about whether we're truly achieving these other things. It's not just one outcome that matters if we think about it from the patient standpoint. So this is my new sort of operational space. So greater Chicago area, almost 9 million people, not counting the surrounding states. If we take just that bicuspid valve, so that's what most of my early research on there, about 170,000 bicuspid valve patients in that area. About 43,000 are going to need surgery in the next 7 years. That's the prediction based on valve or aneurysm alone. If you take that population, that's what the statistics would show. We also have about 18,000 HCM patients. We've probably identified about 1,000 of them, maybe 700 to 1,000. So there's another opportunity, a surgical disease that's underrepresented, underdiagnosed. Okay, so let's say you've made it through all those barriers and you have a diagnosis. You're a young bicuspid valve patient. You've been found to have some aortic stenosis. What are you asking yourself from us? What can we give? And there's a lot of conflicting information out there, right? You can go to the ratings and you can look at where this hospital sits. And on the same day, you can look at the star rating and Consumer Reports, and you're going to read an article like this that says your doctor could hurt you. So there is a lot of doubt and suspicion. And I would argue that that's right. And I would say in particular in the African-American community in Chicago, there are huge barriers to care based on that, based on the suspicion of going outside your neighborhood to a provider and being told you need some sort of procedure. That is a huge barrier. And those are things that we have to work hard to overcome, especially when we see data like this. And this is a fairly famous paper from Mark McCarry. It's a little old now, but this is the original British Medical Journal paper from 2016, looking at causes of death in the US. And number 3 was medical error, which is probably underrepresented based on the fact that autopsy does not determine medical error, at least in the United States. So there's no diagnosis code for a mistake. So all this is sort of inferred from other, other documentation. So it gets to the question of how do we measure ourselves? Like we pat ourselves on the back because of mortality. We can look at observed to expected, but that's one indicator. We who have taken on administrative roles get a lot of other stuff, and I'm sure Mark is inundated with this, as are some others of you in leadership. So you get all kinds of national measures, society-based metrics, other stuff besides SPS, and then there's all the process stuff: readmission rate, bed turnovers, financial related stuff, operating margin, profit, et cetera. Patient satisfaction, there's a patient related one, but really a little bit hard to measure how that is impacted by care versus how friendly the front desk staff was. And we have lots of things to throw at this. And this is a word cloud that's taken from the quality infrastructure at Northwestern, right? You can see some process, services, a lot of management, teamwork, but continuous improvement, right? That's what we're all supposed to be working on. But that stuff is all kind of managerial mumbo jumbo when it comes down to understanding what we're actually doing. And I would argue that all those things are lagging indicators. If we are looking at mortality as a measure of patient safety, we are barking up the wrong tree. That is like looking at the number of airline crashes to see which airline you want to fly. That was true in 1930. It hasn't been true in 25, 30 years in any meaningful way, because the risk is so low now that you have to look much earlier in the process to see what's going on. And I would argue we're getting there. In certain areas of cardiac surgery and cardiology, the risk of a major event is so low, we have to look way earlier in the chain to see whether our quality is improving. So what are the leading indicators of performance? And I want to spend the last part of my talk just looking at this. I would argue this is the leading indicator of performance. It's the team members and how they function together. And there is an emerging body of data in medicine. It's pretty early, but there's a very robust body of data outside of medicine. And I had a great chance to talk with some of the residents about this morning. I would argue that for those of you training in cardiac surgery, there is much more of a parallel between you and a top performer in another world outside of medicine than there is between you and a community practice doc who's in an office, right? You are a member of a very tight team. You take care of very high risk patients. You have a time constrained environment. It's a confluence of factors that's been very well defined in other areas, but we in medicine have not really owned this. We've not said there's a difference between a low acuity office practice and cardiac surgery. That's the reality. We all know it, but there's not a particular set of training metrics around you guys as opposed to your peers who are doing something else. And that is a flaw in the way we measure ourselves. So let's look at this concept of safety for a couple of minutes and how we address that in the global sense, not quality. I'm specifically not using that word because then we get into mortality and prolonged ventilation and all those things that we know. So let's talk about what we don't know. And I think that the mistake that we often make is that safety is confused with process, right? We think that we can throw up process change at a problem and it's going to fix it. And the paradigm for that is certainly is aviation. And this is always brought up as, kind of the pinnacle of safety. And it is. I mean, I flew here from DC yesterday. I'm going to fly back through Toronto tonight. And I'm actually have my pilot's license. I'm a private pilot. So I've done aviation training. It is rigorously safety focused, but not in the way that you think. And a lot of that has been iterative learning about things that go wrong that are not related to what we think goes wrong. So this is definitely safe. And this is the genesis of the surgical safety checklist. And we had an interesting conversation about this morning. We all know about this various checklists that we do in the operating room. No question, this is an improvement in the process that existed 30 years ago. But it has this revolutionized our practice. I don't know how many of you have read the checklist manifesto. Atul Gawande has brought a lot of attention to quality issues, but it sort of implies that if we just follow the checklist, it's going to be fine. This is some data from Ontario. It's a little bit older, but anybody read this paper? I know Mark has. It's a great paper to read. I mean, the take-home message, the conclusions were that implementation of the surgical safety checklist in Ontario didn't make a difference. But if you read the fine print, it's not implementation. It's if you just threw the checklist at a hospital that had a poor safety culture, it did nothing. If you implemented the checklist as a part of a whole revisitation of practice that might impact safety, it actually was meaningful in those places. And that's why the first paper that preceded this showed a massive improvement in mortality. It was like a 50% reduction in mortality. But that was the checklist in the context of doing all kinds of other good things, not just the checklist. Anybody recognize this picture? So this was Korean Airlines Flight 801. If you read Outliers, this is the case study that's shown in Outliers. So 1997, flight to Guam in relatively bad weather, but a very experienced flight crew followed all the checklists to the letter. This was the result. They crashed into a mountain about 3 miles from the airport, and 229 people died. This was not a failure of process. They followed the process exactly. This was a failure of culture. And if you read the book, I'll give you the synopsis. Essentially, the navigator and the flight engineer both knew they were on the wrong course. And they were telling the captain, excuse me, sir, could we maybe look at the chart? Excuse me, is there maybe something we could do differently? But neither of them shouted at the guy and said, you're on the wrong course. And they crashed into a mountain, right? All checklists followed. So this is a culture failure. It's a communication failure. And I would argue there's nobody in this room that has not been part of something in the last month where that happened. This is endemic in medicine. Somebody knows something is wrong and doesn't say something. The whole team knows something is wrong and doesn't tell the surgeon. I mean, that's happened to me, and I'm not the biggest jerk around, but it's part of our culture. It's people assume that if they're in a particular role and they stick to that role, that everything will be okay. People don't tend to put themselves the next level up in leadership in their head where they can say, I'm in charge of the safety of this patient. And so I'm going to voice what needs to be voiced. And people often talk about the culture of safety, which is an easy thing to say, but it's a component of doing those things, of living that culture on a daily basis, which is tough because we're not used to doing that. And we don't train people that way. So to come back to the operating room, and we'll finish off with some sort of practical learnings that started with my journey as a program director in Cleveland and trying to figure out how to make our training program better. It might be of relevance to the trainees here, but how do we think a little bit differently about how we do business on a daily basis? Because this is the reality. As I said, this is a high performance, time constrained environment. It's highly reliant on teamwork. And yet this is the reality. Like, this is what people are thinking during a case. And it occurs every day, right? You work with somebody new who's junior, you're under time pressure, you're trying to get stuff done. And are people ready to take care of those minor deviations that might make the difference between success and failure? Like, I've never scrubbed with this surgeon in this case before. Like, is that an ideal environment for patient safety? You have a great team here. I'm sure this happens. You have orientees in the OR. There's some point where that whole team has never worked together on that operation, right? Which we are very good at making it work under adversity, but is that ideal? That is not ideal. That is not the way we should be delivering patient care. There's a term in the military called VUCA. You may have heard it before, but it sort of describes that the incidents that can happen that we need to be ready to rise to the occasion. And we in medicine sort of sit down in the static and predictable. We're very happy. Obviously patients get sick, but the routine and the sort of the way we function, we're best when we're there. We had a chance to see what it looks like when we're not there over the last couple of years. And I think that, we're all familiar with these images that are kind of emblematic of what's been going on. But what's remarkable, and this is some data from, a group we've been working with in Cleveland and Northwestern, surveying providers in cardiac surgery, that the number of people in our specialty, not just physicians, but across all teams, pre-COVID, the burnout rates were about 40%. People who, according to validated burnout scores, had evidence of burnout was 40%. Post-COVID, it's 60. I would argue the bigger problem is the left side. I mean, everybody knows that that was a really difficult 2 or 3 years, but we started in a pretty bad way. So if we're going to get to that last point, which we talked about, which is, can we provide excellence in a sustainable fashion? I would argue that we have to think differently about how we communicate, how we organize our teams, and in particular, how we train. So the next generation understands all this stuff and is ready to make some differences. And I think that, one of the characteristics of world-class organizations is we invest in learning. So we talked this morning, we largely train surgeons on an apprenticeship model. It works really well. I think it trains good doctors, trains technical surgeons okay. In the US, we're really restricted on work hours, and that has led to less exposure in the hospital to certain things. But if we look at what other people do who are really good at their job, and I put out some examples from the military, but if you just look second to the right, commercial pilot who flies for Air Canada, United Airlines, they spend a third of their professional careers, never mind their training careers, training. So a third of their work hours are dedicated training, not flying a plane in a simulator, recertifying, doing things that they have to do to maintain proficiency. And here's us. A practicing CT surgeon, maybe 1%, 2%. To dedicated, unless you're taking on something new like the robot, I'm sure you devoted some time to that. But in daily practice, and we rarely do that with our teams. We may take, we used to do once every 6 months, a subset of our team would go off campus and do like a code scenario. And it's actually really cool. You spend some time, it's not a time pressure, you debrief afterward, everybody's very excited. We go back to work the next day, 90% of it's forgotten, right? You're back in the daily routine. It's not practiced. We don't debrief. So we asked the question in thinking about our training program, who does this really well? Not who's written about it, not what the data is, but who can we bring in to work with us who is really good at team training and at refining the practice of what they do. It doesn't matter what the outcome is, but the culture and the process and all those things are great. So one example was the Navy SEAL teams. And we opportunistically got hooked up with a former SEAL who was very interested in high performance medicine. And we started this collaboration about 7 years ago with some folks from the special operations community, which is very powerful. That's an overused collaboration, but I'll throw a couple others at you that might be less known. Cirque du Soleil. So if you've ever been to a Cirque du Soleil show, unbelievable. The athleticism of these people, they do it every day, couple of shows a day, has to be perfect. There's a risk of injury. Many of these people are former gymnasts, so they're pure athletes who now have to perform for an audience, and emoting for an audience for a high-level athlete is not an easy thing to do. So this is a superpower team. And their training is incredibly rigorous and their culture is fantastic. So to spend a little time with some of these people, there's an amazing amount to be learned. Here's a very different paradigm we talked about this morning. So one or two drivers, they're the top of the pyramid, right? But it's a very egalitarian team. Anybody can pull the plug on a particular mechanical problem. Anybody can change the race plan based on a mass amounts of data they have, and they can tell the driver what to do based on how the car is performing, which is very different. Imagine if your nurse is going, no, we're going to change the operation today because of X, Y, Z from the patient that I know and you don't, right? That's in our culture. Whoa, like I'm the surgeon. Whoa, right? But there may be some opportunities there. Here's another one. If you guys have ever seen the All Blacks haka, this gets to the cultural component. So, we talked this morning a little bit about what do you do before surgery every day? What are some ways to get the team all on the same page? Here's an ultimate example, maybe a little bit extreme. I wish I could show you the video, but a ritual that the whole team does before a case. Is there anything like that? Even a word that's said that everybody says. I mean, think about every pro sports team before they go out on the ice or on the field, right? Either in the locker room or out on the field, there's a huddle, right? Everybody's on the same page. It's a team building exercise. Do we do that with perfusion? You know, maybe there's a high five every once in a while for a good case, but every case, is there a ritual or a routine? We don't do that. So just in the last few minutes here, I want to speed through a few slides, but to show you some of the work that we did in Cleveland, focusing on if we were to say from scratch, how do we become a high performing team? And this is work that we're working on. And I'll share the slides with everybody so you don't have to take pictures, but I'll send you the whole talk. There are some things that are key here, but what unites us with some of these other areas is having small teams. So we don't have a lot in common with a big company with a sales force, right? I mean, we looked at some of these things to say, do these people have expertise to bring? If we really want to focus on safety, it's people who are in small teams where they're highly dependent on the function of every team member. They work in a high stress environment where the consequences of failure are very high. And there are a lot of those in different industries. And you might say that, all right, if somebody does a bad job in a Cirque du Soleil show, no big deal, but that's a big money event, right? I mean, to them, that is a no-fail environment. So we started to develop this ecosystem of some people who organically were interested in helping us in medicine to do this. And in the beginning, we thought, well, we're going to start with the surgeons. We're going to get some surgeons together that are interested or have connections to this group. And we did a couple cool workshops. This is on the beach in Coronado. You might recognize Terry Yao on the right-hand side there. These guys have their masks all duct tape up and they're about to walk out into the surf with somebody holding on to them on either side. It's a trust exercise, right? Really cool, fun to do. We got in the pool with some Navy SEALs, did some breath work. It's a lot of fun. I would love to do this with my team at Northwestern. I would love to take everybody for a Saturday and go down to the beach with, you know, Jürgen Heitmann, who's one of the Navy SEAL instructors, and do a thing like this. And everybody would come out like totally juiced, ready to roll. Monday morning, it would be talked about a little bit. And by Tuesday, we'd be back in our routine, right? These one-off things, they're so much fun and they get everybody's attitude ramped up. But when we're back in the grind, it doesn't change. Like nothing changes. And so, you know, we think about what some of these cultures have done. And this is one from this book, Legacy, about the All Blacks, where the comment is about the senior leaders in this team sweeping the shed. Like literally that's their locker room. So that the humility that is expressed by the most senior people in the team, I think is just a foundational piece of this. And for the trainees to think about, you know, as you rise up in the ranks, and it's so satisfying for you to be able to go like, I'm in charge, but you don't want to be that when you communicate with other people. And one of the tricks to that, which we touched on a little bit, is a first name basis. So there's very good data that's the learning that came out of that Korean Airlines crash, was enforced across all of aviation worldwide, as cockpit communication is on a first name basis. And that is now the law of aviation across the world. Because what happened in that flight was it was a yes or no sir situation and people were afraid to speak up. And there's very good data that if you use first names, people will speak up. So these are, I think, are some of the foundational elements of that piece. It's the culture that we have to change. We can put all these process metrics, we can do checklists, but if we're not thinking about how we evolve as a culture, and that's all of us, that's the nurses, the techs, the perfusionists. So the couple of foundational components like no rank in the OR, that just helps people kind of be more cohesive. It took me a year in Cleveland for people to call me by my first name. And I was doing a case at night. I came in to do a dissection, and there was a tech that I had never met before who was coming through the back hallway, and he said, "Hey, Doug." And in the back of my mind, I was like, whew. And then it hit me like, that's exactly what I want. This is somebody I've never met before who knows it and is comfortable with it. And but it takes that long. It took a year. And because it was mostly me and a couple of my colleagues, it never really permeated. So now that I'm in charge, I have a little bit of an ability to do that. And we've made that change at Northwestern. That was one of the earliest things that I did. And a lot of people were comfortable with it beforehand, but it wasn't standard. And so a lot of the staff would go, doctor, like if they didn't work with them every day. And now it's just expected. And it has clearly sort of lowered the tension component in the OR a little bit when somebody walks in the room. And the most junior people love it the most. The most junior people make sure to say it. Like the nurses in the ICU who just started, love it. They love being able to call you by your first name. So it's a culture change, but it is a very powerful one. The last one is where I want to kind of round out, which is that we tend not to acknowledge the fear component of what we do. And whoever we are in cardiac surgery, there is a component of that. There is nobody in this room who has not had a catastrophe happen and had their heart rate go up to 140 and their palms get sweaty and their vision narrow. That is just the reality of human response to disaster. And again, there are people who do that really well. So how do we build a culture where people acknowledge that they're going to be afraid and they face it? Well, the guy on the left is part of that culture. Navy SEAL teams, they acknowledge the word fear. They talk about the fear response. They have lectures and courses and workshops on how to manage in combat when you're afraid, how to shoot straight. It's just addressed. It's open. These are super tough people, but they have a curriculum on fear. Like, why the hell do we not have a curriculum on fear in medicine? That is insane. And it's very practical stuff you can do. So you can put the signs on the wall. You can say how great we are as a culture. What we don't want to end up with is this phenomenon, which is often, where we are. We talked about burnout, and there's a lot of data I won't go into from the military on operator syndrome, which is the sort of physiology of burnout. Who else understands this well? Formula One. This is the data that a team is looking at during a race. So there are people who can sort of help us there. So we went to some of these areas and said, we don't understand anything about the burnout response in medicine. It's gotten all this play, but what's the data? Like, you guys understand what the physiology is. So one of the things we did early at COVID is we got a bunch of Whoop devices and we put them on our residents. And then we were able to get some funding to expand that study to 500 providers. That study is still in data analysis now, but it's going to be a great study of what happens to physiology, not necessarily when people get COVID, but in the middle of the pandemic when people are stressed. But I'll give you a few examples from our small study on the residents that are pretty interesting. So this is during a case. This is me on top. That's the resident on the bottom. So heparin is given. Here's the resident sewing. Look what happens to my heart rate, right? So it's not 140, but it's measurably up and it's steady for the whole course of the case while they're doing the case. And then we went from bypass and it's like, whew, that we're done, right? This is a good resident. I mean, they weren't doing a bad job, but there's something about that is cognitive load right there. That is like not only doing it yourself where you can be in a flow state, but trying to help somebody else to do it. And we don't understand how that impacts your stress or your sleep or anything else well at all. But we have to get that data. If we're going to be a high performing culture, we need to understand how that works. So we looked at some other parameters on our residents, and without going into great detail, red is bad. This is heart rate variability, metrics of recovery. Most days of the week, they're kind of all over the map. Some people bad, maybe they're post-call. And then we look at that one on the that's highlighted and look at all the red. Like, what happened there? So that was a night that everybody went out with one of the drug reps the night before to a nice dinner at the Capitol Grill and had a bunch of drinks, and the whole team was essentially out, and that's what they looked like the next day. So is that a good state for our whole resident team to be operating? Probably not, right? I mean, it's not to say that we should prevent people from going out and having a good time, but when you start to get some metrics like that, you realize that we often operate impaired. I'm not saying chemically impaired. Sleep deprived, tired, sick, something is wrong. Somewhere in there's a signal that we should say, it's too much, right? Have a colleague do your case, sub in another resident, do one case rather than two, get some sleep, whatever it is. We don't know, but some people do. This is looking at hours of sleep per day a week. So just to summarize it, the right side is a bunch of special operators who've been trained in sleep maintenance. The middle part is all cardiac surgeons and residents and nurses. So end of the week, we all stink. Beginning of the week, after the weekend, we look okay. So how do we get from the middle to the right? This is a pretty simple thing. Sleep is foundational to performance. I mean, we all know that. Pro athletes spend so much time thinking about this stuff. We're terrible at this. We're really bad at this, just on a weekly basis, never mind call. So how do we get from A to B? And what does that correlate with? This is the inverse. This is Canadian and US cardiac surgery resident. So think about it as the axis is flipped. So the higher you are, the least you're impacted by stress. So 10 is I can manage everything. Beginning of the week, you're good. You tail off toward the end of the week, just like your stress. And this is self-reported. So it correlates with the physiology, right? The sleep is directly measured from the whoop, and that's the self-reported measures. So if we have a complex elective case, should we book it on Friday when we're least adapted, when our team is least adapted, or should we do it on a Monday? Do we think about that? Do we really make decisions based on that? Other people do. Burnout piece, this is the long-term impact. So this is where we are on the left. Every stress, we try to power through it. We do the case till midnight and we go, I can't cancel my case tomorrow because I got to travel. So I get 4 hours of sleep and I do it and it turns into a disaster and it's an 8-hour case and then there's an add-on, right? We just add it on, we power through. But the long-term result of that is that our ability to manage stress and perform at a high level just decreases. The goal is that each of those challenges makes us better, like we're lifting weights, right? But we can't get there unless we understand the physiology and how we adapt to each of those stressors. So this is one of those things we've been trying to understand. And the toolkit to do that is with the residents. And this is where I'll finish up. We talked a little bit about intermittent simulation, like going across the street, every quarter. That's sort of useless. This is the Sim Center at the Cleveland Clinic. I've been there twice. It just is not very helpful to train a team. So bricks and mortar simulation costs a lot of money, can't use it very often. So this is what we came down to for our residents, starting from when they start as interns, which is cheap lo-fi simulation every day. We start out with a month of what's called boot camp, where they round a little bit on the wards, but every other day is simulation training. They have staff oversight every day during that initial month, and then once a week, and then there's daily practice. And there's some data being published that shows that their anastomotic scores went up, within a month. And with this, most of our residents were doing distals by the end of intern year because they practiced every day doing coronaries in simulation. So there's a technical skill piece, not hard. I think I could teach my college student son to do most of what we do if he was focused on it 24 hours a day every day, or 8 hours a day every day, which is not the opportunity that we give our trainees. So the learning there was, for the technical skill piece, it's a lot of lo-fi simulation. But what about all the other skill sets we talked about that come into the high performing team, like situational awareness and those kind of things? So this is kind of the paradigm that we've taken from these other areas, including professional sports, which is technical skills is a lot of lo-fi, high rep. The higher level skills, maybe we can leverage some things like VR. So situational awareness, you can actually measure where people are looking in the operating room. You can track time to decision. There's some tools being used to do that. But where we really need the most data is on our stress and adaptability. And that's where there are starting to be some multi-institution studies. And I would love it if you guys want to participate on that level. There's a group with Mark Moon out of Baylor that's putting together a consortium actually to look at kind of surgical physiology, surgeon and trainee physiology. It's just a brief look at one of our early primitive VR tools. So some 3D video shot in the OR, just looking at how residents kind of interact with the field. And these tools are rapidly getting better and better. When it comes to our teams, we have to take a little bit different approach, which is to try to assess where people are in their attitude and understanding before we can even start some of this work. And this is a design sprint we did as part of a retreat at the beginning of this year. We brought in a facilitator. We took a whole afternoon off from the OR with people from all the teams that are involved in taking care of patients. You can see people doing, putting ideas up on stickies there. It's a very sort of design-centric process. But this is kind of some of the feedback that came out of it. And people felt like the teams are strong. They were worried a lot about family issues and the effect of stress on their family and coworkers. We had some support from one of the former Chicago Fire coaches to do this and brought in some sports psychology ideas to this. But we did a couple of assessments that I think are valuable as a place to start, which we asked people, all right, today, before we start any of this new stuff, because I was new to Northwestern after doing this for 5 or 6 years in Cleveland where people didn't think I was crazy. Where are we today? If you're a nurse in the ICU, where are we on the performance axis? Are we a high performing organization, low performing? And how much trust do you have in your own team? And we're in kind of a good spot. So you can see all those little stickies are in the middle of the performance. So they think we can get better, but there's a lot of trust. If we ask the same question about the organization, the whole blob moves to the left. So people have a lot less trust in the hospital than they do in us, which in a way is not bad. I mean, I think that's actually a good place to start. And we asked them overall, you know, how do you feel about being able to speak up in a situation and when something is wrong? Where one is, I'm afraid to speak up, and 4 is, I can always speak my mind. And we showed this data to some of the leadership. They all clapped each other in the back and said, we're a great institution. We have a great culture of trust. And I said, how come so many people are in the 3? Like those are huge opportunities for us to avoid disaster. The 3s who sometimes speak up, because those are probably fairly expert people, but who don't usually contribute. So to wrap up, I think that the foundational factors that we need to work on, and I hate to end this talk as a very early work in progress, but I think this is where we are. We're starting to get some data. We're starting to think about ourselves like other high performing organizations, but these are sort of the foundational pieces. And I will say that the last 2 are the most difficult. So the pushback that I've gotten in the last 2 hospital systems that I've been in have been, can we get access to all the data we want to get to understand this? Meaning it took 6 months to get permission to put whoop straps on a bunch of volunteers who wanted to do this study to figure out what their sleep looked like. And I had to go through the CEO of the hospital to get permission to do that because they didn't want that data to get out, that people might be sleep deprived. Like, come on. And the third one, which is radical transparency, which is, do we give all this data to the teams? All this process improvement stuff that we're trying to do. There were a lot of people who said, well, we need to kind of keep this behind closed doors until it gets published or until we sort of understand what the data means. And as a first principle, we said, no, everything we're doing gets shared. Any team member who wants to get access to it, any team member who wants to participate, nurse, tech, whoever it is, can be a part of the team, can be part of the research planning, can, you know, spin off projects, whatever they want to do. But all the data we have about how we're doing as an organization gets radically shared. That's still a work in progress on the financial side, but we're started to get some more inroads into some of these other factors but I think that is foundational. How do you get people to buy in into getting better if they don't know where we are? We can't keep that stuff a secret. So I'll finish up coming back to this partnering, which is a plea to all of you. We had an amazing conversation over the last couple of days, and I would love to continue the involvement with this institute, with Northwestern and with other places who are interested in not only in the day-to-day stuff that we do, training residents and fellows and having those exchanges, those things that are easy, but in the thinking about some of this higher level stuff. There are a few places that have leadership that is as forward thinking as you do. And there are a few places that have an organization that's capable of doing this. So I think there are probably 5 or 10 places in North America where we can do some of this work, where people will buy into it and are interested in it. And so I would love to have your partnership and to put Ottawa Heart Institute at in the nexus of this ecosystem of people who are interested in high performance medicine. So just leave you with, how do we improve? Remember those values that seem to be so much shared between our institutions. Be humble, and we have to continue to look outside for inspiration and information. Thank you very much.
This was such an amazing talk. One of the very best lectures we've had in this named professorship. I think everyone would agree. Very humble, very humbling, a lot of very important elements and kind of discovery points around the impact of culture and team building. And obviously, as you say so well, humbling because we have such little data, right? And we don't know where to draw the line. I really love so many of your examples, including some stuff we say. You know, we go to meetings on Thursday, we say Tuesday morning, same thing is going to be exactly the same as it was, right? And you feel you have so many of those meetings where there's great intentions, but it's so hard to change a culture. I don't know, Allison, can we see questions here? There's no questions. Maybe I can start with one before we open the floor. Where do we draw the line? Like, where do we, because you mentioned the Korean Air accident, but there's also many examples, for instance, of innovation, of progress that have come from someone leading a team, and sometimes even against everybody else, right? And one contemporary example would be, whatever you may think of him, Elon Musk, for instance, right? Everyone thought it would be impossible. And I think there's been great advances that this guy was crazy. He is crazy. And he calls his kids on, but it was teamwork. Obviously, he was able to build the chemistry around this. But there was also this kind of incredible, innovative genius. Where do we draw the line? I'm sure there's many people who told him, look, Elon's not going to happen. This is garbage. This is not safe. Your autopilot, everything, right? And we probably don't have the answer, but where do we draw the line? And Air France 447, for instance, an example of a horizontal culture that led to a crash in the South Atlantic Ocean, right? So it's hard. And I think your research is going to be really, I don't expect you can answer that question, but we need to situate, there has to be team dynamics, but in the same time, there has to be a just culture. I don't know if you have any thoughts around that.
I love that point, Mark, and I don't have any wisdom there. That's the world according to Johnston. But I think, talking to people in cultures that have very well-functioning teams, what they will point to is a visionary like Elon Musk can set the very high-level goal, can say, I am inspiring you to do these things, and I'm going to put resources behind it. But what he's also very good at doing is having teams of well-resourced, intelligent people and letting them run with it. And SpaceX is a very open culture like that. Actually, I had a chance to meet some members of that team, and that's a place where it's like, this is your job. Go do that. I don't care how you do it. We're not going to monitor your hours. Nobody cares where you sit. So a very open culture in the working groups, but obviously very top down in terms of the goal setting and those things. So I mean, maybe there's a paradigm there that, that there are leaders who have to set the mission and set the vision and to some extent the parameters. But what we don't do well is let all the members of the team rise to the level after that stuff. Like, you guys do the best job in the OR you possibly can, save patients. Everybody's empowered to do something and to grow that culture of, it's sometimes called leader, where on a daily basis, it's like you have this whole group that also thinks of themselves as leaders and functions in that way. Even if their thing is how I clean the room better, great, because that's a component of performance. But I get what you're saying. If it's too egalitarian, you don't get that initial spark, the vision or the direction, which is important, no question.
If I can just follow up, it's just absolutely fantastic and inspiring. And this is a bit of a conflict in culture, because the traditional medical training is individual oriented, right? You really actually want to be the expert. Yet the reality is that you need to work within the system in order to actually have those things to be effective. We're kind of blessed at the Heart Institute from the point of view that there's a relatively flat organization, probably is a function of a smaller size, which is actually great. And then the other aspect is that people really take tremendous pride in being here. And that really is one of the ingredients that, avoid some of the burnout and that there's a, sort of a collaboration. So the question I have for you, actually, I want to follow up with a comment is that a lot of times for us to improve, we need to actually stand in the mirror, as you mentioned, sort of looking at, getting ideas from outside. And this is where collaboration comes in and the partnership. We talked about this yesterday. We're so excited in doing that. One of the things that, in terms of team, and you talk about, the huddle is, I think the key to communication. Sometimes I walk in the OR, everything's very, very quiet. But I wondered whether, for example, you could actually have this type of a mini huddle so that, for this case, this is how, sort of how do people want to actually, do this? Are there things we should be worried about? And then actually run it that way. And then, sort of really have the ability to build a team as the operation is going on. Sorry, this is going from outside, so not anymore.
I think your point about we didn't get into some of the tool sets, which I think that's what often seems like an insurmountable problem. But things like how does the briefing work? How does the huddle work? There are some very practical things to do, all of which we've stolen from other organizations about how to make that a team building thing. And one of it was the surgeon never leads the huddle. The circulating nurse leads the huddle. So that means they have to be prepared. They have to understand the case. It typically makes them bring up issues that they're worried about because they'll talk to the other members of the team beforehand so they don't screw it up. So, and it's done in front of the patient. And so kind of becomes an exercise of bringing the rest of the team up. And if in the huddle, the surgeon doesn't have to say anything, that's ideal, that the rest of the team is already, so it might be just going, oh yeah, don't forget, we're going to clip the appendage or something, but that the rest of it is all, the one of the most powerful things, which is very hard to do with the timing that we have, is debriefing. And I was telling the residents this morning, we had 2 pilots with us observing. And so we said, we're going to do like a real aviation debrief. We're going to have them lead the debrief. And I did a mini thoracotomy. I thought it was the best case I'd ever done. It was like an hour and 50 minutes, skin to skin, beautiful case. Everything went fine. So I'm like, we're going to rock this. These guys are going to be so impressed. So we get in an office, and they asked me to start the debrief. They said, say one thing you did wrong, so that will sort of set the tone. So I said, well, I was late to huddle because I had this patient, and so I apologize. I set him back by 10 minutes. And I thought, oh, we're done now, right? We had 15 action items by the end of that debrief. There were all these things that I didn't know that were going on in the background. The valve sizers were missing. The cross-clap timer was broken. We had a new orientee who didn't know about a particular checklist. There's all this stuff that was in the background that would have been just sort of like, we'll fix it next time. Incredibly powerful. And the team was like in it. I mean, they were all weighed in. They felt like they were really part of it, but it's really hard to get the whole team together at the end of every case. I'm sure it's the same here. People disperse, so much work to do, but it's something that other cultures of high performance do very rigorously that we don't do. And it's usually a very egalitarian discussion. I mean, even in the military, which is fairly hierarchical, that's a, you know, it's like the best M&M we've ever had, you know, where there's real discussion, but they do it every time. So I don't know how to fix that problem. We've tried to institute it multiple times and it's never worked, but that's a powerful one.
Doug, I really enjoyed that talk. That was fantastic. Certainly a lot of themes that I think a lot of us will try to decant over the coming days, weeks, and months. I guess my question really relates to a little bit of what you just mentioned about the amount of work you have to get done, the amount of time. Most institutions will look at volume and access to care as a metric of quality. So you have a lot of work that you give to the same number of people. Do you try to work a little bit less? How do you manage this? I was telling Rob, and we're in line to this microphone, that at AATS, I was talking to a bunch of old fellows that I was at in New York and other US centers. And one of these guys was telling me how he got kidney stones 3 times last year. Scrub for 12-hour cases, couldn't drink water. Where I did my training, my old boss would call it a weight loss program. There's no fellow that does not lose 30 pounds over the course of the year. So a little bit of that is the amount of work that has to happen with fewer bodies. Everyone's under the gun for financial, professional, patient care reasons. What is your view of the balance of that?
That is an excellent question with no easy answer. What I'll say is I think this is a huge area that we can all do the research on and drive it. I mean, there are analogs where, you think about some of the process changes that have been made because of like a single malpractice case or some financial loss or some perception of risk that a hospital will say, we have to totally reimagine, and sometimes in very counterproductive ways because of a perception of risk. So we've tried to start to flip the paradigm in conversations with hospital leadership. And fortunately, our new CEO at Northwestern is a physician, a very forward-thinking guy, is very interested in performance. And I said to him, Howard, if we want to differentiate ourselves on quality, we have to be deeper into this than other people. So there's a magic number here. What if we said Northwestern devotes, 3% of productivity to training? There's a magic number there. Somewhere there's a number where in cardiac surgery, we're going to get closer to what aviation does. I mean, aviation does 30%, right? That's how you get to safety. That's almost zero events. But we're never going to get to 30% training. Maybe we don't need to. Maybe it's 2 or 3%. But somewhere there's a magic number where this X% of the bottom line gets put back into this effort. And I think places are starting to wake up to that, to recognize that if you do, and I think COVID drove a lot of this, that now there's this perception that if you let your teams get to the point of self-destruction, it costs, just never mind the human cost, but it costs an immense amount of money. It costs $300,000 to hire and train a new PA, right? If we lose one, that's the cost. It costs, $160,000 to hire and retrain a nurse. So you add that kind of stuff up and you'd say, what is the retention of a really cohesive, happy, well-trained team? You may be able to make the financial case even there. I'm not saying it's easy to do that, but I think we have to think at that level of reinvention to say, what, if medicine is really going to be what it should be, what do we want to look like in 10 years? It has to be a very different culture. And part of that is where the money goes. So, the payers may end up driving this. Maybe, in your case, the government system will say, hey, these are the places that exemplify quality and they devote this much time to training. And we're looking to the actually private payers in the US who are very open to that, believe it or not, because they think the quality will be better.
And that was kind of, you already answered the question I was going to ask, but thanks. It was a brilliant, brilliant talk. Really, really appreciate that. I really appreciate you coming. Maybe if I can ask one question, you kind of glossed over it a little bit when you showed the trust bar, the 3 to 4s and so on. You made a comment that if you had the administration up there, it would be the other way around. And so just concepts around trust of the administrative leadership and how you might change that. I mean, you have got a new CEO and everything, but how do you evolve that as well?
So I'll give you a very brief anecdote. So part of multiple improvement efforts, we were trying to look at just OR throughput. How long does it take to get the patient prepped and draped, and some of these metrics for getting through the OR. And I was trying to get the data, and I went to this OR quality improvement team, and they said, you can't have that. That's our work. We do that. You can't have that. So, well, we're the surgeon. We're actually doing the cases. Like, why can't I get the data? That is the biggest frustration of the on-the-ground teams. When we kind of debriefed after that retreat, and we said, why is your trust in the administration worse than your trust in your team? They said, because my team tells me what I need to know. My team is transparent with me. The administration is not. The administration is always hiding something. That was literally the verbatim that a lot of people said. And so it gets back to that radical transparency piece. And I think this is very difficult when we have to say, I mean, there are certain things you don't necessarily want to share that are on a personal level, salary differences and stuff. But most other things, like, why can't the average provider know if the organization's financial performance is good or bad this quarter, or what the underpinnings of that are? Because some of those come down to quality. Why can't we share all the throughput data and all the, I mean, it's stuff that people hold on to for no reason that creates this atmosphere of mistrust. And so it's one of the things we've been trying to change in the culture there, is to say, we're going to start to generate a lot of data that people are going to be a little iffy about. Like, we're going to generate sleep data and heart rate data on our, our providers. And we went through this in Cleveland. We weren't able to share it outside that small group, short of what I just showed you here. Northwestern's a little more open, but I'm hoping that that'll be like, we're all sleep deprived. I mean, what a starting point that would be to say, exactly, maybe we reorganize our shifts a little bit. Like, let's get that data out there. But I do think that that's one of the biggest issues. When we talk with our frontline providers, they think that the administration is secretive, and that's where that mistrust comes from.
So kind of on the opposite side, the sort of the individualism and the egos of physicians. And it's not unique to surgery. Cardiology, all medical practices have this kind of egotistical point of view, like that central, they're the one making the decision. So how have you kind of changed that mindset to create that team environment that allows people to be able to speak up, like you gave the example about?
Well, I will say one of the biggest tools there is bringing in people from the outside, not just to sort of help us with our research questions and these quality improvement, but to talk to the teams. I mean, if I go and talk to a bunch of nurses about how we should rethink our communication in the OR, everybody's asleep or on their phones. Nobody cares to hear that from me, right? But if we bring in a Cirque du Soleil artist to talk to them, people are riveted. And for our residency program, we started we call performance visiting professors. So we bring somebody in from outside once a quarter. And the most highly rated speaker was, his name's John Michael Shirt. He's a ballet dancer. He used to run American Ballet Theater. And he talked about how a ballet company prepares for a performance. And it was fantastic. And, but that was a game changer for the residents. They looked at this guy and they went, wow, this actually resonates with me and my preparedness. And so I think it's having that outside perspective is very powerful. And fortunately, we have this great group of people that wants to help medicine get better. So a lot of these people would come in for free and because they thought it was cool.
Cirque du Soleil does not have a single star. There's not one star in the show. Right? It's everybody.
Thank you. Thank you very much, Doug. That's superbly insightful. I guess I have two questions. The first one has to do with when you're already a top tier performing institution like Northwestern, the Cleveland Clinic, a Heart Institute, and you're trying to squeeze, as you said, those last few drops to get to even better results. What is the strategy behind there in terms of, just looking briefly at the different phases, if you can just kind of list for us what preoperative, operative, or post-operative, what are the things that you can do to really squeeze those last few drops out and improve your performance when you're already at that top tier level, aside from what you obviously spoken about today, which is crucial?
So, I mean, there's a lot of stuff we all already do. I mean, root cause analysis when there's clearly a sentinel event, M&M, I mean, foundational to everything that we do. We all get so busy that I think we tend to focus on the highest level disasters for those discussions. And the one thing I've learned from these efforts with other high performing cultures is that it's debriefing and analyzing your good cases that makes you better faster than debriefing and analyzing the bad ones. It may be obvious the stuff that goes wrong. And in our world, sometimes it is the patient. I mean, we can always say that. Sometimes we maybe have a minor screw up with a very sick patient that causes a bad outcome that wouldn't have been a well patient, but it's the opportunities that exist on a daily basis to improve. And that's very hard for us to do, to look at a day that goes well and go back and say, all right, let's rigorously examine that. But that's where we, I think, start to get at some of those, like you said, what are the preoperative things? What are the misses, things, near misses that can happen in the pre-op phase? Albumin that's uncorrected, creatinine that's bumped a little bit that we could have waited a day for surgery, those kind of things that we often get away with, but we don't really rigorously re-examine. And same in the OR. I mean, I would say, there are times when if you stood and you watched an operating room with an excellent surgeon and very good people, that you can, when you do that, when you go visit sometimes, you'll say, there's communication problem here. Like, this anesthesiologist is noticing something that nobody else knows. And they're, you can get the sense that the wheels are coming off a little bit, and usually it's fine. But I honestly think that those are the hardest things to tease out, but those are the things we have to tease out to squeeze that last bit out. It's the minor mistakes that can iterate into the snowball that results in a real problem.
Thank you. So I guess the second question has to do with the culture and how you change culture, and what do you do when you meet resistance? I mean, I was at the Cleveland Clinic only 3 years. You were there for 17. So we kind of both understand that some of the culture has been there for a while. It's anchored, and to change some of these things, you're probably met with some resistance and some challenges. So how do you go about tackling those challenges?
Yeah, changing the attitudes is a key step, even though it's not the follow through. It helped me a lot to have partners who were, a couple of partners who were interested, and it was not the leadership. I mean, I'll give you one example. We wanted to do 360 assessments for everybody on the team. Not a real detailed one, but some starting point where people could kind of get a foundation. And I stole this idea from the Cleveland Indians. Their general manager, Mike Chernoff, as it was on the Princeton baseball team, is a super smart guy. And their entire organization, down to the guy who paints the lines on the field, has a 5-year personal development plan. It's amazing. I mean, the culture is just fantastic. And so we said, well, let's do like a mini 360 on everybody on the team, ICU nurses, OR, surgeons, whatever. And our leadership said, no, we're not doing it. They said, you can do it for the nurses, but we're not doing it for the surgeons. So, well, why not? So we might hear some bad things. Well, that's what a 360 is about, is to try the good and the bad. And then you look at, but anyway, we weren't able to do some of those things. But over time, it was the mid-level surgeons at the clinic who really pushed a lot of this stuff forward. And then once a bunch of ORs were doing something different, it was hard, for the leadership not to buy it. So it's a slow process. I'm not saying any of these things is easy or that we did it well. I mean, these are obviously, this is to talk about a lot of snippets. It's like pieces of the puzzle, but I don't think that we're even close to where we need to be.
Thank you. I guess the last comment was pertaining to your slide asking whether or not you wanted to do the reoperation on a Monday or later on. And it reminds me of what Costa Pedersen used to ask us, would you rather be operated on Monday or on Friday when the team is warmed up? So I guess you have the data now to prove him wrong or to give that answer, right?
I think if the team were getting sleep all week, it might be Friday would be the good day. I mean, the problem is that people get progressively fatigued. And that may not be that hard a problem to solve. I mean, we just need a couple more surgeons or a few more nurses so that people aren't doing so many extra shifts, and it would look better. Or that people just need to be trained about their sleep better. I mean, that's one of the bigger issues. So
thank you so much.
yeah, absolutely.
Doug, this was really a great lecture. So many important tidbits, and we want to thank you on behalf of the Foustanellas family and the foundation and the Heart Institute and everyone who's here. And we received many comments offline from texts and attendees who were virtual, who said how great your lecture was. So truly one of the very best we've had in this capacity. And we want to thank you again for really your acumen and your leadership and your bright career, already an example to our young surgeons and to all of us. So thank you for bringing this young, fresh leadership perspective to culture and teams and so many of the, I would say, right brain, right hemisphere aspects of doing high-level cardiac surgery, which we don't talk about. We talk about left brain aspects, right? How do you size up an aortic valve-sparing aortic fluid? But the right hemisphere really got a lot of attention during your talk, and we're very grateful to you for that. Thank you.
Thank you so much.